go. Good morning. We have the countdown on our side here. 3, 1. No, 3, 2, 1. I can't count. It's too early. Well, welcome everybody tuning in this morning. I think we should have called this breakfast tango or something. I guess most of us and you already had their first coffee. I did. And for those still in... Okay, no, first thing. 3, 2, 1. I can't count. It's too early. Oh, it's you.
Oh, you're in your session.
I'm in my session. I tuned in. So, my name is Verena Voelter. Good morning, and very welcome to my co-hosts for this morning, or co-moderators. I don't know how we should call each other, or Martin and Kelly. So, Martin Geisenhainer and Kelly Irving, as we are discussing why the heck does it take 5 to tango in healthcare. And so a quick word to myself. I'm a physician, have been working a lot, many years in the clinics as an internist and oncologist, and then pivoted to the biopharmaceutical industry and worked there as in R&D and medical affairs and commercial roles for quite a bit. And now started my own company, 5P Healthcare Solutions, and wrote that famous book on Tango in healthcare. So thank you, Kelly. And good segue. So obviously, Kelly and Martin are going to say a little bit about themselves too, but it's really my honor to welcome them on this podium this morning. Kelly, my book would not have appeared in how it looks like now without Kelly, the wonderful editor coach. And she always says, but Verena, every word is yours. That is very true. But if listeners now say, Verena, you know what? What I like most about your book is the stories and your stories with patients and your stories in pharma. And like, well, then you can say thank you to Kelly. It was her idea. And also she helped me forge it into the form it is now, with 2 parts and 5 chapters and an introduction and a foreword and a preface. So all these structural ideas were Kelly, and we'll explore them during the hour. Welcome also Martin Geisenhainer, who is a leader and I should say founder of the Swiss National eHealth Network Initiative. So knows a ton about eHealth and very passionate about connecting people, what I observed Martin being around in the ecosystem. And then obviously Martin was the obvious kind of ask from my side, because what you see in his background is not a fake background. I was told. Is a real background with only books. So welcome, Martin and Kelly.
Thanks, Verena.
Thank you very much, Verena, for having us. And yes, right, books are some of my passions are books. And so I'm very glad I received your book as well, Verena. And I really loved reading it. But one question before we start. Do you tango?
I was fearing that question. So let me take a detour. I'm a passionate dancer. I like to swing on the dance floor, and I'm very glad we have a party coming up again after like 2 years of Corona lockdown and partying just for myself. So yes, I love dancing, but I haven't been enough on the dance floor recently. I'm passionate for I should say Hispanic and South American inspired music and tango. I visited Uruguay, and I bought actually on a flea market 100 years old flyer, we should call it today, on a tango group that was announcing their concert 100 years ago. And I fell in love. And when I was looking at this and reflecting on what's the title to my book? In English, obviously, we have the saying, it takes 2 to tango whenever there is a problem. And I think that's what we're talking about here in healthcare. Not everything is rosy. There's a ton of problems. And so I felt, well, actually in healthcare it takes 5 to tango. The short answer is, Martin, unfortunately, I don't know to tango yet.
Okay.
But I tango quite a bit on the healthcare stage.
Okay, yeah. I mean, the title is very catchy because we all know 2 on tango. But with 5, it gives some funny pictures in my mind. But what I think is special, and I'm not a dancer, is that tango is not a dance like any other dance. Mm-hmm. It's not that mechanic because you have to react to each other. It's something that happens, and you don't have to learn steps, but you have to do it together. So, what is this image with the 5 in your book, with the 5 participants on Tango?
Yeah, and I love that we stay a little bit on the Tango piece, because I think that was the other inspiration to me to choose the title. One I already explained, but the other was in one of the many webinars I think we all did during the lockdown. I came across one business leadership webinar with a Tango teacher, and I'll tell you how that connection came to the title. But the 5 really are, if you think about it, and I think it's we see it on the icon here in the bubbles. So it's patients receiving care, providers providing the care, it's pharmaceutical to a large extent developing the care. Obviously, underneath is also the whole life science sector. MedTech is also developing care. Academic research is contributing to that care too. But like as a short kind of placeholder, this middle P, the pharma. And then payers have to pay for that care, and policymakers that often tend to neglect, at least when we think about it strategically in terms of collaboration and co-creation of solutions. But the policymaker, of course, that's very different for us in healthcare as an industry, has to safeguard the ethical guardrails for anything we do and administer and work around human beings and their well-being and their lives. So that is very different from any other technical industry. And so those are the 5 that kind of need to dance. But as you said, Martin, there is no rules on how they should dance together. And that's why it's not a cha-cha-cha and it's not a waltz.
Yes,
I love it.
And you're providing us with some ideas or recommendations on how to do this, right, Kelly?
Yeah, actually, I want to stick there a sec, because there's something really nice in this. So, you sort of started the session, Verena, talking about your credentials and who you are. And I think, most of us would know you as a doctor. Most of us would know you as a business leader. But the thing about this book and remembering about you is it's a very deeply human book. And there's a lot of you in this story. And you have been, you've almost played at some level in one of those 5 participants. So, who are you as a human? What drove you to write the book? What's that deeply human kind of element for you?
Yeah, and I remember that sentence, everybody has the book in them. So I knew I had a book in me, but I so much don't like writing. So I never thought I would get it out there. Now that it's there, I totally relate to it as what you're saying, Kelly. It's so me. It became a very personal book at the end. And I think I wanted to share that quite unusual duality. Pretty much when I looked back, I spent half of my life in the public sector. I mean, from my professional life, and half in the private sector. And that's a little bit unusual. It's not like the most common experience. And looking at our issues we have in healthcare and a lot of the blame that's going on and the feeling of guilt and the feeling of finger pointing, who's put a default it is that we're running out of cost and the quality is going down. And I was reflecting, I was thinking, there's actually more commonalities among the public and the private sector and among those 5 than there are divides and differences, despite being deep silos, those 5. So I felt personally, I really want to tell my stories on all the good stuff that's going on and the best practices and growing the community of practice and giving back those stories, because I feel like just sitting on those stories myself and the experience in my home, not telling anybody, it's useless. It doesn't help anybody. So I wanted to really share the learnings and the good things and the possibilities to bridge those silos. I wanted to share it.
I think that's really timely as well, because I think it would be really remiss, at the start of this conversation, if we didn't address where we are right now. And, I think, the issues or the underlying sense of stuff being wrong in the healthcare system, not working for us, it's always been there, but I think it's been particularly highlighted at the moment with COVID and all that kind of stuff going on. One of the things that I love about you and your work and what you put into this book is that you flipped it in terms of, well, it's not always a bad thing. Like we really focus on the negatives that have come out of it, but actually there's some positives to come out of this. Can you tell us a little bit more about that?
Yeah, I think, and honestly, I started thinking about writing a book before we even knew what Corona or COVID is. Yeah. And then I started writing it, and then COVID hit full swing. And I thought, oh my God, I'm not going to write a book because there's more important things, in the world than my stories. And then obviously half a year into the pandemic, I was like, no, now is the moment. I have to write this book. It's exactly very timely. And I think some of the positives, and of course, COVID also magnified and amplified issues we have in healthcare. But one of the positives is the many public-private partnerships that have occurred. Because if you think about it, and I think that's one of the quotations in my book, is like, guess what? When there's a huge emergency and you have no other alternative left in terms of life or death, collaboration works, even in healthcare. And so if we think about it, we have at least 4 vaccines right now. And these 4 vaccines were developed in less than 12 months. We already kind of now take it as a given. And we're fighting over what's the best vaccine. And people are fighting, should we vaccinate in the first place? Or no, vaccination is very bad. But if you think about it, it is unprecedented in human mankind. So human mankind always had pandemics. And for anybody, watch out, there's going to be another one. Maybe not in our lifetime, maybe, but for human mankind, there is. But never did we have a vaccine for a pandemic. And then our regular drug development cycles, and many of us, I think this morning or in general, are working in drug development or in discovery in the academic side or in the life sciences sector. It takes, on average, in the past, it has taken over a decade. And it has taken over $1 billion. And, it takes over 10,000 molecules from the bench to find that one needle in the haystack that really helps patients. And thanks God, we have a ton of new medicines, particularly in oncology, my background as a cancer doctor. Phenomenal last 2 decades with new discoveries, new therapies for patients, really things that have significantly prolonged, actually, longevity of people. But it's a very risky business. And I already said, it's a hugely expensive business to drive progress in medicine. It's like nobody can afford it other than largely the private sector in the biopharmaceutical space. And that's why it exists, because they're able then to carry the risk. So what's happening in public-private partnerships is you share the risk and you share the cost and you do open crowdsourcing of data and information. Remember the early days, I think still to this point, any new scientific discovery and data are actually open. You don't need to have a subscription to a journal to read a new COVID scientific article. It's all open. And that's why it took only 11 months to develop for a vaccine. So it actually works. And the question I'm asking in the book, and everybody, for us as we grow the community of practice, why the heck can't we replicate this in normal lives? Mm-hmm.
Yeah.
And I'm giving also a few other examples in the book, other than COVID, where it also works.
Yeah.
As a teaser.
It seems like such things only happen if we have a crisis. Mm-hmm. Or seem to happen when we have a crisis, which is a sad experience or a sad perception of this. And what I like in the book is the first part we learn about the health system. Who are the stakeholders, the partners in the system? What's their interest? And how do they collaborate today? Well, how do they collaborate today? Do they?
Yeah. So if we look at the many positive examples, the positive examples usually usually only occur because those actors and dancers work together. Because usually, if you think about it, the solution to our problems we have in healthcare, 9 out of 10 times lie outside of our expertise. So, for example, if you want to change the fee-for-service model we have in healthcare, so everything is kind of money-driven, the hospital alone can't change it. Pharmaceutical alone can't change it. You need the policymaker to set certain frames, and it depends on political systems in different countries, how they get their healthcare system organized. So you have to have the policymaker in that conversation. You need to have the insurers in that conversation. So it's like, and certainly the patient can't change any of this on their own, right? So it's like this huge, deep interdependency, and all the good examples always only are fruitful when these people have collaborated. But in many places they don't. And one of my kind of observations while I was researching for the book, but also reflecting on my own path and journey working in public and private, is that we often do not even appreciate and have no awareness about the interests of these other parties. So typical dinner conversation around high drug prices, for example, on the market is. And then I'm saying, well, have you ever reflected what the needs and pressures are for a pharmaceutical company and a pharmaceutical leader? And the typical answer is, what the heck? Why does pharma even have frustrations? They have tons of money. Why are they frustrated? And so it is actually encouraging everybody and say, and that's the tango theme. Put yourself in the shoes of the other dancer and your other partner that you, as we know, you are intimately dependent upon. We cannot work without pharmaceutical. We won't have the progress in medicine we have today. Period. It's a fact, if you like it or not. So we have to, same thing, in terms of maybe we have too many hospitals. Maybe we have too many hospital beds. Maybe there's things going wrong. For sure there are things going wrong. But I think we cannot finger point and blame and go with pressures. I think we need to understand the situation of each other and then find common ground on how to solve it together. And I think that is kind of where the deep silo mentality will not go away if we don't start thinking of the other dancer's situation and start thinking what are their pressures, because we need to help them address their pressures, and only then can they help me and us address my issue, and then we can come to a solution together. Sounds a little bit theoretical right now, but it's kind of the tango concept. Yeah,
no, it sounds absolutely rational. But there's one central pair of shoes on this dance floor. That's where the patient is stuck in. And I think the patient is always, not always, but very often the last one the others are thinking about. And the patient, so is the main victim. Sounds a bit strange, but yes, I would say so. Yeah, the main victim of this fragmentation in health system. What's your thoughts about that?
Absolutely. And as I was reflecting on some of the root causes, as you have referred to, Martin, in like the whole first part, so part 1 of the book is all around, like as a doctor, I would say it's about diagnostics. Get the diagnostics right, otherwise we can't treat the illness. And so we have basically a broken balance, and I like this kind of balance with the pebble stones on one side and, this imbalance. And if you think about it, because we have fundamentally flawed incentives in the system with I'm saying too much money in the system, we don't lack actually money and investment in the system. There's enough money, and I'm, explaining why and how the numbers add up. But if among the 5, if you think about bargaining power, huge imbalance with maybe the most bargaining power sitting in pharmaceutical. Insurers have quite some bargaining power. Policy has decent bargaining power. Doctors maybe have, depending on what the situation is, a little bit of bargaining power. The patient, I guess, zero bargaining. So, what if a patient speaks up and, complains and is frustrated, what can they do? If they have a nice doctor, the doctor will listen. And they can. So I think those are it all starts, I think the major axis in the whole healthcare system is the patient and the doctor. Because no doctor, no care. And so I think they have a central almost responsibility together. And I remember, Martin, you and I had a conversation some months ago. I think it was in a podcast where, as we were speaking, we were discovering, well, the patient has some, maybe not bargaining power, but certainly an empowerment to also contribute to change with asking certain questions to their doctor, or coming up, with additional ideas on, what are other lifestyle choices, social determinants of health. What are other things I can do, for my situation? And the doctor kind of leaving a little bit the maybe old paternalistic type of culture and get more down in terms of an eye-to-eye conversation with patients and co-creation, what is good for health for the patient. So I think there are a lot of great ideas that are stemming out of this.
Yeah, can I add to that, Verena? Because there's a couple of things in there, but I think one thing that you just described there is, using your voice, and a book is a great platform to raise your voice and to share your message. Equally, it also gives your readers and an audience a place to raise their voice and share their messages. And there was something actually that came out from another author's discussion interview that I had with Denise Colazzo. And I remember her saying, no one can give you a voice. You have a voice, you have to use it. And I think that resonated really nicely with what you were just saying there, in terms of, we all have a part to play in this, and we all have a choice to use our voice and raise some of these issues and talk about this stuff. I think that's a really nice way of looking at it. I don't know what you think about that.
Yeah, and I think it goes back to your earlier question, like, why did I write the book and why it's so personal? And I think it is that part is to, now in the stage of my career, in my life I'm right now, it's really around two things. It's around growing the community of practice, and then obviously through my business also help really coach and consult on projects. But I think it is around that first pillar on growing the community of practice and helping maybe those that have at least a little bargaining power, to give them a voice. And I think, Kelly, one of our first coaching sessions, I remember, and everybody says that, right? When you start writing a book as an author, you need to have this one reader in mind, like that one person. And I'm like, no, I have 5. I can't do that. But I have to admit, now I can say it, that the patient was always there. I guess it's just because I'm a doctor. But then next in row is my peer doctor group, because I really feel for them. And I feel, because I'm not in the clinics these days, but I think it became very obvious, and you mentioned COVID earlier, obviously we can't have this conversation without, or by ignoring that there is a pandemic. So it became obvious to everybody, like healthcare workers burn out, particularly in the first wave. And it became very, I think, hit the images and pictures in the press with New York City in the early, like in March or April last year. But even now, and I think in Italy and Bergamo, etc., and the physicians being completely, and nurses for that matter, burned out. And it is a huge issue out there, doctors burn out. And same thing, I think some other people may say, what do you think? Physicians, they're so rich, they make a ton of money. Maybe that is true, and maybe that is true for some of them. But I think we need to take a systems view. And from a systems view, the majority of doctors are burned out under the pressure to produce. And if you speak with them, many of them, 8 out of 10 will tell you, I would love to have more time with my patients. I want more time with my patients. I want more time to talk about all the non-pills related conversations we can have that have impact: nutrition, movement, mental health. All these things require quality time, and the human touch takes time. Our system doesn't allow it because we are driven by fee for service. We are driven by money because we are all in this interdependent vicious circle. You know, the hospital needs to make money. They have a bottom line and ROIs they need to deliver. The insurers, they just work in the system that is given, right? I mean, healthcare insurance in Switzerland or in Australia can't just say on Monday, oh, we work with a different system. they can't just decide that overnight. So,
Verena, I've actually got a question here from Michelle. She said, too often policy lags well behind medicine's development and technology. What advice do you have to raise the patient voice in changing policy?
Yeah, I think obviously it depends a little bit on the country with different outlets. And that's what my mantra is always think global, but act local. So some of the principles we've been discussing over the last half hour, they are absolutely globally relevant. But then the implementation locally is different. So, but what I would encourage everyone in their country, in their region, I mean, there are things like public advisory groups where patients can be very active. Then if it is not directly the channel to the policymaker, sometimes there are intermediary societies and groups that do actually have an access to policy. So you can get active actually in those 1 or 2 layers underneath. We had a really nice clubhouse session yesterday with a couple of patients. One of them is very active in Switzerland. We have the Swiss Cancer League where patients can get active. There are more and more groups, also particularly in the provider sector, so in hospital settings where we are driving value-based healthcare transformation. So that is actually the modern solution to fix fee-for-service, is that we actually incentivize on the outcomes, the results that matter to patients. And that's actually happening in many places in the world. And I give a ton of examples in chapter 3. But there are ways where you can actually get engaged with other patients. I'm working actually, maybe, I don't know if she's listening this morning, but I'm very active with one patient also in Switzerland and beyond. And she's actually testifying in the book. So if you want to read some of her ideas, she is a public speaker. She built her own company. She's speaking on world stages, on conferences. For example, in oncology, the ASCO, American Society of Clinical Oncology, which is actually international, almost Society of Oncology, they have a huge patient group, a huge pillar where patients, are active. There are not scientific, but there are journals out there for patients with patients. So there's a lot, but one needs to search. And I'm very happy, by the way, to have a conversation with whoever is interested to learn how to do that in their local environment.
What about some of the basics? So what, as a day-to-day, you walk into a doctor's office.
Yes.
Is there anything you can do from a patient's perspective?
And I was thinking about myself, because we are all patients eventually, right? We all sometimes go to the doctor, let alone to the dentist or to our GP to get a COVID vaccine, maybe. So I was actually starting with myself. I'm like, wait a second, I'm going to my GP and they're using pen and paper. And I'm like, for years I've been thinking, why the heck are they using pen and paper? And I asked myself, did I ask my doctor why they're using pen and paper? No, I didn't, because I didn't dare. I'm like, oh no, I'm not going to ask my doctor. Who am I, right? I'm just a little patient. I'm not going to ask my doctor what. And I said, you know what? I wrote a book. Now I'm going to have the courage. So not everybody needs to write a book to have courage. So I'm like, go and ask your doctor. And don't judge, just ask. And I got wonderful feedback. One of them said, Verena, I know electronic data capture, electronic patient dossier. It's great. I love that it's coming. But you know what? I can't even type with 10 fingers on my keyboard. I just can't. So, and then we were brainstorming. I said, well, maybe we need to do an education class, a weekend class, and help these guys. It sounds stupid. Why not? But ask. Have a conversation.
But that's a wonderful point, pen and paper, even though I love pen and paper. And when I write on pen and paper. But maybe that's not the best idea if we have a fragmented system where everybody just have data on his own. personal system or on his personal paper. And that's when we start to part 2, the doing. And Tango is something which has to do with doing. It's not thinking, but doing. So digitization is one of the points where we have a lot of things, tons of things to do. I mean, we are digitized for years now. We write emails instead of letters. But finally, the system itself is not integrated yet, not the slightest bit. And you have some thoughts on this and some recommendations in your book, which I thought were very interesting. So what would you give our listeners and watchers with on the way?
And I'd be curious, Martin, to hear from you too, because you're driving, as we said, you're working with Nanny, and it's one of your flags you're holding up. So curious to hear, what your approaches are. But I think so the fee-for-service system, which is really the root cause for our broken system and for the waste and inefficiencies we have. But for many years, we didn't have the tools to do it better. But now we have, value-based healthcare principles, we have digitalization, and we have a playbook with the Tango on how to dance together. So I think if you start with hardware, IT interoperability in hardware systems, so let's say if I'm a patient and I have whatever stomach ache and I go and get a gastroscopy maybe, and then there's a finding, but then the doctor needs to refer me to the next specialist, and maybe they're in a different city, in a different region, in a different state, or in a different hospital, let alone down the road. And this other hospital uses another IT infrastructure. So they can't share, for example, radiology images. So you go with your CD-ROM in the worst case. In the best case, they can do online, transfer of data, but it's not compatible. Guess what? And that is our reality, I guess, in 3 out of 4 situations. So I think that is, again, something where the collaboration and conversation with the policymaker needs to happen, because hospital A cannot just, yes, they can ask hospital B, do we do the same IT infrastructure? But this is not how it's working. So there needs to be a concerted, almost political and regional healthcare systems approach to say, and many of our countries are federalistic countries, right, where actually healthcare is owned by the state, the region, the Bundesland, or the canton, or in Australia, the region's own healthcare. But certain things must be centralized, and there must be a centralized decision to say IT infrastructure for whatever data sharing, let's take the Swiss example, Martin, with the electronic patient dossier. This is a federal decision, and that's how it has to be. And yes, it takes a decade to implement, but it's the only way. We can't do it separately. So I think, again, good example where for a Tango for 5, where one actor alone can never make that progress. But I think we all have the opportunity, and maybe I'm saying provocatively the responsibility, to lead in that field. And that's what we all here are doing. And I think many on the online that are listening and contributing are doing this in their day jobs.
Yes.
What's your thought?
Yes, absolutely. I think it's very often, if we're talking about systems, IT systems, we have players who look just for their own interest. So they want to sell products and they want to sell their technology. So I think maybe we should be open to something like open by design. So we have kind of a system which can be modified and changed by everybody. So we have all contributors and all stakeholders have the same chances and the same opportunities to make a contribution. And so maybe the system will be much more open and much more valid for the whole system. But of course there is a lot of fear by especially the patients as well when it comes to a dossier, for instance. You named it, which is centralized somewhere. So the fear is everybody can now see my data.
Yeah, and I think that is a lot of conversations are happening right now, realizing that maybe one of the major roadblocks why we are not more advanced with digitalization in healthcare. Because if you look at other industries, they're far more ahead of us to implement digitalization. And one of the reasons is probably exactly spot on, Martin, what you're saying, is a trust issue. Is a trust issue and a literacy issue. And literacy is a complicated word, standing for just literate, like the keyboard, right? Knowing how to type with 10 fingers on a keyboard is a literacy piece. So it's just knowing how to work with an app and work with an iPhone. And obviously, generate the millennials and Generation Z and maybe Generation Y are very literate in using all these tools. But let's look at, some of the mega trends of our societies. One of the mega trends is aging. And look at the elder generation. Let's look at our parents, our grandparents. How literate, how easy is it for them to use an iPhone? If I look in my family and surrounding the 80 and 90 years old, I can tell you nobody has an iPhone because they like the little Nokias with the very large, buttons. That's what they love. And the only thing they need to do is call their grandkids. That's all what they need to use it for. So I think we always think, it's obvious everybody has a smartphone and a tablet and computer anyway. We have 100 devices in our homes. But this is just a minority of the society, and it's maybe the ones that are least ill, that need it least for healthcare. So I think a huge opportunity, again, also, Kelly, for what can everyone do or every patient do. I think get engaged in how we can help each other build that literacy. And, I heard yesterday actually a startup that is collecting old smartphones to distribute them to patients who need them when they undergo a therapy so that they can use the digital health app. But maybe there are, in underserved communities, for example, or the caregiver, for example, needs also a device and they can't afford a device. So there are ways to get engaged and involved in this whole transformation. And obviously education is important. And I think in Austria, for example, they're planning to build a digital health academy, like in Germany, Volkshochschule. So, classes for everyone. Also to ask questions, I think, Martin. When we have, also in Germany, we have huge criticism to the elektronische Patientenakte, both from the public and from doctors. And we also have the EPD criticism or lack of adoption, let's say, in Switzerland. And we need to help people to ask all their questions and have open forums and sessions where people can feel their part and they're heard. Because I think that's where our issues are. We are so traditionally conservative, hierarchical, and paternalistic, and say, we tell you what is best for you, including an EPD, and you must trust. It's not working like this. So I think this co-creation, again, the cooperation and co-creation idea to build that trust is key. What's happening with my data? How is it, what is a cloud? Cloud in the sky. But what is a cloud where my data are sitting in the cloud? Oh my God.
Yeah, I wrote down, Verena, I love the direction of this convo because I wrote down the word collaboration because it came back right to the start, which is the whole essence of your work and this book. And I think there's so many levels in this because I think with a book especially, we tend to approach a book, we're putting our knowledge and our experience and our expertise into a book. But actually, we still need to come at it with a beginner's mindset. I'm not the expert. This is my sharings. This is my learnings. This is my experience. This is the pool of research that I've gone on. And this is particularly something, you did so exceptionally well in this book, giving examples. You even touched on other industries, how it's working, blah, blah, blah. But ultimately, this is part of a wider conversation. And I think, yes, you're proposing solutions, but you're not saying it's this way or nowhere else. It's actually, this is the starting point. This is, you're trying to give people and encourage people to start the conversation because that's the only way that collaboration will happen.
And thanks for that reminder, because sometimes, like on the business side, with my company, in my consulting work, not often, but rarely, I have somebody asking, "Oh, can you come in and fix that problem for me?" And I'm like, "Well, no, not because it's not my job to do that, but because it's an expertise thing. So I don't have the expertise in all these 5P. My expertise maybe lies in seeing the connections between the 5Ps, but I'm not a payer. I am, God forbid, certainly not a policymaker. There are people who are much smarter in doing this. And so it's for each of the 5, right? Maybe the most closest to me is the physician, but even being a physician, what does that mean? They're gynecologists, they're like, orthopedists, I'm not a surgeon. So the expertise sits, and rightly so, with each of the players and each of you and each of us. But I think what I can help is I can help to see the bridge, and I can help to build the bridge. But I'm not kind of helping in solving the problem per se. And I think that is I think it's a different mindset, because it's not only for me, I think it's for all of us, because recognizing that maybe it also takes off pressure to know, well, it's not expected of me that I fixed a problem. What is expected of me that I maybe think about who else can I work with and who else can I call up to help me fix the problem. And I think that's I guess that's a different, not yet so common.
Yeah. Yes, and I see the book as a wonderful invitation to every stakeholder to join or create a community where collaboration is possible, and where co-creation is possible. I mean, we don't know the solution. Nobody knows it now. Yes. We have to find it out together, and it's us to find it out together. We cannot delegate it to a consultant or something coming in and fixing the problem. That wouldn't work. We have to do it ourselves. And so actually I mean, you have some ideas. It's a workbook as well. And in the last part, you demonstrate some possible steps as an approach. But finally, it's an invitation to join us and do things.
Yeah, no, absolutely. And I think it's a nice, I'm looking at time. We're probably getting close to wrapping up. But I think the nice closure with the tango piece, as we said, there is no fixed set of steps like a waltz or a cha-cha-cha or other dances. But actually, what I particularly like is that there is a set of vocabulary that the dancers have. And that's maybe the 7 steps of multi-party collaboration that I'm suggesting based on the Harvard Negotiation Project. But the piece I like most, somebody in the beginning said, "But Verena, where's the conductor? Somebody needs to conduct these 5. I'm like, yeah, that's what we are wishing for. But there will never be a conductor telling the 5 what to do. They have to figure it out themselves. And it's in tango, the 2 dancers actually can swap leadership position from one to another. Because in traditional dance, the man is leading, like I guess all of our society, but that's a different conversation. Tango always has been the case that the 2 partners, the woman and the man, but there's also, you can also dance 2 women or 2 men, but they can swap instantly who is leading. And they have this nonverbal vocabulary to know when they swap leadership. And I'm like, wow, this is exactly what we're doing here. It's not that the policymaker has to dictate how we do it, or the insurance company or the pharmaceutical industry certainly doesn't have to dictate this, but we actually can, depending on our expertise in a conversation, somebody takes the lead in a certain part of the meeting, but then we swap it back to the other one who has maybe more expertise for a payment model or for, how to set up a new IT infrastructure in hospitals. So then you let these people speak. But it's really kind of the true essence of co-creation that the Tango model is suggesting and that the book is suggesting. And there are some skills you can learn, how to learn that vocabulary. And that's what I guess I'm proposing to help with. But it's not going to be, the book won't have the ingredients to fix your problem that you have.
Yes, great.
Great.
Can I finish just by sharing a little quote that I love from this book, because I think it sums it up. There's a little quote that I called out. Healthcare is not a commodity. It is a centre pillar in our societies. If we want to value our health, we need to value all parts of the healthcare chain equally. I think for me, that kind of sums up everything you presented in this book and, what you've spoken about today, Verena. It's like the heart of your work to me. Thank you.
Thank you very much, Kelly, for today, but also on the whole journey with the book creation. And thank you so much, Martin, for engaging and driving what you're driving with all your other work you're doing in the community. And thanks to our listeners this morning and later, because I will be recording.
Michelle, Maria, Cameron in particular. Maria said congratulations. But anybody else who wants to contribute to the conversation, I would encourage to put some questions down. But that also, where can we go to keep the conversation going with you? I know you mentioned Clubhouse before as well.
There are a few channels. One is the tango45.com website, which has a blog. So everybody highly, welcome to put down your thoughts there. Certainly, I think LinkedIn has become a quite good platform to exchange thoughts and engage in the community. So there are different ways. And you can contact me directly, also over my website, 5phealthcaresolutions.com. And otherwise, simply through responding to this recording that will be a post in the blog on LinkedIn as well.
Yes.
Most importantly, where do we buy the book?
That's it.
Michelle is so right.
On the tangle5.com, and obviously any bookstore.
Yes, and then follow Verena on LinkedIn and just read the book and then start doing.
Exactly. Thank you so much, and happy dance, everyone.
Yeah, thank you. Thanks, Michelle, for your insightful question as well. I'm sure Verena would love to connect further with you.